we're going to take a little turn and focus on data and data strategies and analytics. And I'm so happy to have Amanda with me today. She is a strategist and an expert in this area of data, and not just collecting the data, but how do you form data into usable, meaningful solutions. So Amanda, just speak a little bit about yourself, your background, and what you have planned in your career.
Good morning, everybody, and I'm so excited to be here. Thank you so much for having me. And Zena, it's great to be chatting with you, with the audience here. So I actually have an interesting update to what I'm doing now. I'm very excited to share it with you all here at the HITLAB Digital Health Symposium. You're actually the first to hear in the first public forum. So I will go over my biography, but the quick update is that I have left Amazon and I have joined Stanford University in a new role, which is reporting across the School of Medicine, the research institutes, and the hospital system, Stanford Healthcare, to lead external industry partnerships. So I am excited to be working with all of you in the future. Briefly, the remit there is to bring the best of external technology solutions into Stanford to further the mission of the university and the School of Medicine and the hospital. So super excited. It's quite the commute here in the Bay Area, but I'm really looking forward to it. And it's my first week at Stanford, and I am adjusting to world post Amazon. Very briefly about me. So I mentioned Amazon. I spent a wonderful, engaging, challenging, and exciting almost 5 years there. First launching and then sadly shutting down Alexa Health and Wellness, an initiative to make Alexa, the friendly talking AI in the Echo device, a healthcare assistant in your home, where she would refill your medications, remind you of your 30-day post-discharge plan, make you appointments, check your claim, etc. After that program was shut down in 2021, I moved over to AWS, another part of Amazon, where I led the AWS Healthcare Accelerator globally in our 5 regions, helping to find the best external startups solving challenges for enterprise healthcare and life sciences customers, put them through a 5-week boot camp to get them ready to do business at scale, and then launch them into those enterprise customers of AWS with a little data integration help from us. Before that, I did a tour of the healthcare system, all of the P's. Payer, I was at Aetna. Purchaser at Purchaser Business Group on Health, a big employer coalition. Provider system, I'm back there now, but before I spent time at New York City Health and Hospitals Corporation and Mass General Brigham. The state, I guess public would be the P there, California Department of Health and Human Services in the exciting days of health information exchange, and pharma at a company called BTG that had oncology and pulmonary therapeutics and was bought by Boston Scientific. The last P is the patient, who I think is the most important to serve in all of these. And I'm still trying to drive towards that endpoint. So that's me in a nutshell.
That's absolutely incredible, Amanda. You have really a 360 view, I think, when it comes to value-based care in particular, and how all of these P's kind of contribute to that, and the important aspects of gathering that data and making it meaningful. Could you talk a bit about, that I think what you referred earlier with me was that data puzzle, and how you work within a value-based data world, which relies heavily on clinical guidelines and trials and claims. But how do you put it all together? As you mentioned, it really comes down to the patient.
Absolutely. Such a great question. Thank you. And those of you, I'm here on the West Coast. Obviously, it's my first week at Stanford, so I didn't get to make it out to the Digital Health Innovation Week. But those of you who are there, please share what you're seeing in reference to this question. But what I think is super exciting about the transition to value-based care, there's a lot of debate over the different types of business agreements and designs, and then there are the very helpful naysayers who say that all of this is just kind of on the layer on the top of the cake, and everything's still running on a fee-for-service chassis. And I think that that's a good corrective to make sure that we're, you know, moving the ball down the field as much as we can and really converting to value-based care. But here's the big data challenge that I think is really interesting. I don't need to belabor the fact that fee-for-service tracks outputs, right? We all know that. It's how many times you cut, how many times you drug, how many times you admitted the patient, how many times you did a thing. Literally procedure codes and ICD-9 codes internally, right? And DRGs. So we track what was done, but not what happened. In an ideal world with value-based care, we'd be paying for the things that are effective in improving the outcome of the patient. The problem is we don't know what those things are. We have clinical guidelines, right, which are based on studies. We have clinical trials, which tell us about the comparative performance of certain therapeutics against doing nothing. Let's remember that a control is the standard of care. So it's not quite doing nothing. That's a misnomer, but it's what we do today. But it's a strict binary. If I give somebody everything we do today plus one item versus everything we do today, does that change mortality? That's really the data that we get through clinical trials, and that's what we use as the basis of approving reimbursement and writing guidelines and encouraging certain quality measures, et cetera. You know, that's a bit of a shaky foundation on the great summation of all of the clinical care aspects, behavioral lifestyle changes, social determinants of care that would really ensure that everybody is optimizing their health status to the extent that the cost basis will bear it. And I'm a little concerned that we're rushing towards a value-based care world, and we don't have great data on what creates the best outcomes. We just have a bunch of data on what has been done in the past. And what I think is really interesting is that AI, while a very powerful tool that we are only beginning to understand, can only learn on the data we have. And we don't have great data in what, you know, yields the best healthcare outcomes. We have a lot of ideas about what doesn't, right? We know social determinants of health can really inhibit optimizing health status when people don't have healthy food, or they're horribly isolated, or they continue to smoke because they don't have the support to quit, whatever, you know, name your item here. But we don't know what positively drives outcomes. And sometimes that's not incorporated into clinical care because it's beyond the scope of clinical practice, essentially. So I would love to see who is building the data set around the positive inputs that are not just correlated, but causatively affect the positive outputs, to figure out how we're going to economically weight those. You notice I'm looking for somebody else to do this. I'm not volunteering. And build a model that positively suggests at the point of care in a lightweight way things the clinician can do that will yield the right outcome for which they will be rewarded and should be rewarded under value-based care. The AI can only learn from a foundation model that includes that data. And I don't see a lot of people like feeding the beast on that. So I'm really excited to see where that will go.